To those who've arrived, welcome. And we will wait just a moment or so to allow people to arrive and settle in, and then we will go ahead and get started. Terrific. Okay, well, welcome to all who have joined us today. My name is Sarah Willen. I am an associate professor of anthropology here at UConn and an affiliate of proud and grateful affiliate of InCHIP. And it's my great honor today to introduce our speaker, who will be speaking about a collection of topics that relate in complex and interesting ways, and will bring a deeply interdisciplinary approach to issues that are of concern to many of us. So our speaker today is Dr. Lawrence Yang, who is professor and interim chair of the Department of Social and Behavioral Sciences, associate director of the Global Center for Implementation Science, and also founding director of the Global Mental Health and Stigma program, all at New York University. He's also the principal investigator of an initiative to promote global mental health and wellness that's funded by the Li Ka Shing Foundation. Dr. Yang comes to us today with, as I said, a deeply interdisciplinary background, which I know personally I'm so looking forward to hearing expressed in his scholarship. He's received extensive interdisciplinary training, including training in clinical psychology at Boston University, in psychiatric epidemiology at Columbia, and in medical anthropology at Harvard. Dr. Yang has received 6 national awards in stigma research, including the Maltz Prize for Innovative and Promising Schizophrenia Research from the Brain and Behavior Research Foundation. And he's currently PI of multiple NIH grants and has published over 145 peer-reviewed publications in journals such as JAMA Psychiatry, the British Journal of Psychiatry, and the American Journal of Public Health. Dr. Yang is also applying his expertise to address the novel topic of migration stigma, which will soon yield a book from MIT Press that's anticipated this year. So without further ado, I'd like to turn the floor over to Dr. Yang, who will deliver a presentation titled Stigma of Health Conditions in the Global Context, Applying the What Matters Most approach to mental illness, HIV, and cancer stigma. Please join me in welcoming Dr. Yang.
Thank you so much, Professor Willen. I really appreciate the gracious invitation and introduction. Count me as well as one of the admirers of InCHIP from afar. It's really great to meet you all virtually today and share with you some of these ideas that I will be discussing today. So you can all see my screen. I'll take that. Sarah, that's a yes? All right. So,
in fact, we could a moment ago.
Oh,
I think we need another minute here. Yes, thank you.
Sorry, thank you.
No.
Shall I try again? Yeah.
There we go. Thank you.
No, of course. Thank you. All right. So again, thanks for the gracious introduction. Professor Willen described, all of my sort of my current positions, so no need to repeat them. So I'm meeting many of you for the first time today, and so just a little bit about my research background. So I do, my work splits into 2 camps, so to speak. So the first is in global mental health, and so I'm doing work in task sharing in global mental health, and then also cognition of untreated psychosis in China. So that occupies a lot of my time, but I'm not going to talk about that today at all. I'm going to be speaking about the work that I've done in stigma of health conditions. And this is actually a deeply held intellectual commitment that I've had to this area for since the very beginning of my career. So starting in my K Award, which is, I can't believe it, but almost 20 years ago, where I started to examine this issue of culture and stigma of mental illness. And more recently, I have then brought this work to HIV. This is about 2015, so about 8 years ago. And then most recently, I brought this to the stigma of cancer. And I will be presenting on each of these topics in some depth, except for cancer, I'll just touch upon briefly as it's the newest area. And in addition to the core theoretical work that I myself and others have articulated, I've really taken this work to and applied it to both measurement and stigma interventions. As noted earlier, my background is quite interdisciplinary. So let me start by just describing this idea of what matters most and stigma. I want to begin with this. I want to begin with and then leave you with this big idea that I hope that you may find relevant to your international work in HIV in particular. So I believe that what matters most is relevant to global health, stigma, and social integration, and I'll be describing that in many ways today. And so in relation to stigma, so stigma is seen to threaten what matters most to people's daily lives in local cultural worlds. And like I said, I'll enliven this concept quite a bit as I go through, but I just to introduce it to you now. So I'm going to take you through a journey that I've had with this concept. In first of all, uh, during its inception, when I examined it during my K Award among Chinese immigrants with psychosis in New York City. That was in 2005 again. And so I had the opportunity to really develop the idea, over a decade. And it's had some influence, fortunately. For instance, in mental illness stigma, I was invited to present at the National Academy of Sciences in 2015 around this idea. In 2015, I then had the opportunity to bring it to HIV in Botswana, so pregnant women with HIV in Botswana. And recently, I participated in an NIH working group where I was able to further articulate these ideas in relation to intersectional stigma. And then most recently, as fate would have it, National Cancer Institute now is interested in stigma in low and middle income country context. So the idea has also found traction in yet another area. So I know there are a lot of trainees on this call, and I just hope that that maybe you can take inspiration from if you have an idea and you stick with it, it can yield fruits over time. Because anyway, so let me walk you through the first example, and this is among Chinese groups. And so, I'll walk you through, give you a little bit of a crash course on some core cultural orientations within Chinese groups. And so, okay, so I'll walk through each in turn. So, renxing. So, renxing is this concept of reciprocity. And this is the give and take in social relationships. So, just like in the US culture, there's a give and a take to relationships. Typically, if you receive something, then you return the favor, right? At some future point in time. And usually around the same magnitude of the favor, right? So in traditional Chinese groups, what happens is actually it's a very regimented, the give and take. If someone gives you X, then you return X plus 1. But then that person returns to you X plus 2 at some future date, and then so on and so forth. This means that you have the impetus to continue the relationship. In traditional Chinese groups, if you return X, the exact same amount as you received, it's actually seen as incredibly damaging to the social relationship because it means that I no longer wish to continue to reciprocate with you. So that's one concept. The second concept is that around guanxi or social exchange networks. And again, this works in certain ways like US culture. So if I'm connected to InCHIP and hopefully, and likewise. And so I can, people can refer me to people with their network, et cetera, et cetera. But what's different among Chinese groups, again, is that you're actually able to borrow materially from anybody within the guanxi network. So for instance, let's say you're part of this blue person's network, all of a sudden, and you're allowed in, and you have guanxi within that group, you can actually borrow materially from anybody in that network. But the thing is that you have to show that you understand renxing, right? So if someone borrows from you X, you borrow from somebody X, then you have to be able to return X plus 1, right, at some future date. And so these capabilities are deeply intertwined. The third is that around face. I'll talk a little bit more about this in a bit. But face, in a nutshell, you can think about how it's reciprocal obligations. It's this participating in these reciprocal obligations and showing you understand these is, and especially to your family members, who you sort of owe the greatest reciprocal obligation to, shows that you have face in or standing within the local community. And then lastly, perpetuation of one's lineage binds it all together. So it's not just obligations to your current family, your temporal family, but to your ancestors who came before you, and then your descendants for generations to come. So let me show you. So in this work, we also discovered, okay, also discovered a concept that, illustrated a concept that I think applies to many different cultures. So here in Chinese culture, this is concept of face, and there are two forms of face. Let me walk you through the first. And again, in traditional Chinese settings, mianzi. So mianzi is social standing. Social standing is, for instance, what kind of car do you drive? What kind of job do you have? Do you live in a nice house? That sort of thing. You can lose mianzi in many ways, as you can see here on this left side of the slide. However, if you work through extreme effort and accomplishment, if you lose mianzi, you can also regain it. So you can imagine, right? You lose social standing, but then you work really hard and you can restore it. There are ways to do that. There are ways to express that in the Chinese language. However, there's a second form of face that is actually even more fundamental, and that's about being seen as a decent human being, again, usually tied to these reciprocity obligations. And you can see here, there's lots of ways to describe how you lose your lian, all right, or this fundamental sort of, being a human being in the social world. And you'll note here on the right-hand side, we have not been able to find, and I've checked this with a lot of Chinese folks at this point, there is no way to express how to get your lian back if you lose it, all right? So let me just let that sit with you for a moment, because what this says is that if somehow you end up losing this aspect of humanity, there is no way, even within the Chinese, within the language itself, how to express how to get it back or how to restore it. So I think this is a beautiful depiction of Arthur's concept of social death, which I'll be referring to throughout today's talk, or of non-personhood. And it's this essential dynamic of if you lose these markers of personhood within a local community, it is impossible to get it back. There's just no way back. And that's the fear that many community members in different local worlds hold. So let me now bring this to the illustration among immigrants, Fujianese immigrants in the New York City. And so just a little bit about them. So this is Fujian province. It's located in southeastern China. It's across from the Taiwan Straits. Mountain is not good for farming, and it's near the coast. So there is a long history of immigration out into Southeast Asia, and then in the last several decades to the United States. And the first port of call is in New York City. So when they arrive in New York City, they are influenced by a host of structural factors that put them at great disadvantage and risk. So first of all, they're brought in by a network of smugglers, so or snakeheads, that work together to bring them into the country. They come in and owe an enormous, a very high debt to the snakehead gang. So at the time of the study, this is 15 years ago, keep in mind, it was $80,000, and there's a massive interest, like 30% a year, if you base in terms of paying back the debt. So there's enormous pressure. If the immigrant does not pay the debt back, they're at risk of violence and death from the snakehead gang. They then are smuggled by different means into the US, and then because they're typically lower education status and undocumented, they're consigned to these menial jobs, typically in the restaurant system. So life as a Fujianese immigrant, even if you're healthy, is pretty tough. You have to work for 6 years, 14-hour days, 6 days a week, and then you could pay off the debt. You can imagine what might happen if you develop psychosis or schizophrenia, and all of a sudden you can't work as well, and that condition is highly stigmatized. And also, the restaurants that hire you are within this local network. They all know each other, etc. So if your status is discovered, you may not be able to get a job. You can't get a job, how are you going to pay back the debt? And again, you're at risk for violence and death. So, people say to me, stigma is terrible all over the world, mental illness, etc. And I absolutely agree. Stigma in all its forms is incredibly harmful and damaging. In this particular example, it could mean the difference between life and death. So this is a picture of the Futsunese being detained at the New Mexico border. When they come into the country, they have to pay, excuse me, there are 4 post-migration goals. So the first is really goal 1, 2, and 3, for obvious reasons, given the circumstances I described to you, is to pay off the migration and travel debts. And they spend 6 or so years doing that. After that's accomplished, if they're able to do that, they then send money back to natal families in China. This enhances the family's prestige and face. And then the third goal then is to, if they can, perpetuate the family lineage, because again, that's a core value. And what happens is then they typically sponsor a wife to come over and then have to pay off her debt, travel debt as well. And then this was more possible at the time of the study, less possible these days, but to attain legal status in the US, back then it was through asylum procedures. So that's the Futsunese group. Now let me bring all of this. That's the Chinese group, Futsunese group, and how they live in New York City. Now let me bring this context to stigma. So let's just focus on this bottom bar for just a little bit. This is a crude heuristic to show that in the middle, you've got the individual sense of self. On both sides, you have basically radiating out different social domains. So you have social functioning, family, life opportunities, work, education within larger society. And stigma, according to the Surgeon General's report in 1999 and many other empirical studies, really impacts every aspect of a person's life. And we've shown this across many different studies at this point. So this is where the work that I got to do with Arthur Kleinman comes into the picture. So during my K Award, honestly, up until that point in my career, we had known that stigma looks different in different cultural settings. It looks different in China, it looks different in Botswana, the United States, different ethnic groups, et cetera, et cetera. But up until this point, I believe, we did not have a rigorous way to conceptualize how it might differ within different cultural locales. So I went to work with this preeminent medical anthropologist, Arthur Kleinman, really giant in the field, and we sat and thought very deeply about this issue. And so in 2007, we published a paper in Social Science and Medicine on this very topic. And let me just read to you the key sentence from this paper. It reads, "Mental illness stigma acts in culturally salient ways to impair an actor's capacity to take part in the core everyday engagements that certify one as a fully viable or fully moral member of a local community." So let me speak a little more plainly for the non-anthropologists in the audience. In every culture and the local worlds within that culture, people participate in a set of everyday engagements that mark them as a full-fledged person within that local community. All right. And and when other people see it, they say, "Oh, person X is participating in engagement A, B, and C." And so they recognize it. It's a shared value that everybody recognizes. So, so again, stigma affects everything. But according to this theory, where stigma hits people the hardest is among these capabilities that determine personhood, okay, or full sort of status within the local community. So let me make this very concrete. So for Futsunese, I've described to you what their local worlds are like, that stigma ought to coalesce most forcefully around a Futsunese individual's capacity to obtain competitive employment, repay his debt, fulfill filial obligations, and extend the ancestral line. Because these are the activities, everyday living engagements that matter most within a Futsunese local world in New York City. So I just want to make a little bit of a theoretical note. Professor Kleinman actually refers to this this concept as moral experience. I go back and forth, moral experience, what matters most. I found that in the beginning of my career, that moral experience was a very confusing term for sort of the non-anthropological folks. So I've, shifted towards what matters most. I think it's just more graspable. So this paper, I believe, has filled a gap in the field, and it's been widely cited since 2007. So it's very very grateful for that because it took a lot of deep thinking. So again, stigma impacts uh, the individual in all aspects, right, of an individual's experience. But according to this theory, it coalesces around, again, the capabilities that matter most within a local world. And I believe one of the real strengths of this theory is that what matters most differs by local world, right? But we can discover it through rigorous ethnographic and qualitative methods. And I'll illustrate that in a second. So, um, 7 years later, 2014, I completed 50 interviews with Chinese folks with psychotic spectrum disorders, primarily from the Fujianese group in New York City, in 2 inpatient units. And so this is a lot of these details in the studies are from published studies. So I would just encourage you to please take a look if you are interested in the different details. Again, I'm just going to lead mostly with the core findings and the ideas in order to really stimulate thinking. So the questionnaires we used are around were around the internalized and experienced stigma of the client, and we did qualitative data collection. And then I'm going to present to you the codes on FACE and what matters most. So I'm just going to dive right into it. What matters most from Fujianese individual's perspective with psychosis? And I remember this interview vividly. I was talking with this gentleman on the inpatient unit, Chinese inpatient unit. I'm going through my stigma questions, right? And you know what? He's obviously gets fed up, and he just breaks from the interview altogether. And he said, "This is what he says to me: Just to bother you to talk to the psychiatrist for me to be discharged sooner. I myself want to work because my illness is well for more than 2 weeks. I don't know why they don't discharge me. What I mean is that I'm going to help out my parents, my father and mother. Mother still works in the restaurant. She's almost in her 60s and she still has to work. I want to help her just to go to work. That's all." Okay, so what matters most to this gentleman? Well, it's very clearly, obviously, it's work. But number 2 in here, you can see embedded is this filial obligation, right? He has to reciprocate in terms of supporting his parents. And if he doesn't do so, he will lose his face in the local cultural community, and he's at risk of losing his personhood. This is something that's urgent for him to achieve. So, in terms of the theory, did culture or what matters most shape the way that stigma was experienced? And so, again, according to the formulation, right, it's not just the fact that this gentleman has psychosis; it's because it's shaped around the ability to earn money, because this is the thing that is, the most essential sort of card-carrying aspect of membership for this group, right? So let me just read you some illustrative quotes. So the first quote here: "My family members look down on you when they found out that you have this condition." Patient response: "No, it's about your ability. If your ability is good, they will do their best to help you. If not, they will neglect you." Another quote: "Why would the patients on the unit be looked down on? Because many patients are looked down by others. What I heard from relatives was that the patients just become sick, and the relatives think the patients are useless and will not care for them. Patients are unable to make money, relatives would not come to visit the patient, and some people even are afraid to pick up the patient when they are discharged." So again, here you could see that it's not just the fact that they have a person has psychosis; it's the fact that they cannot earn money that is really damaging to them in the community's eyes. So that's all well and good. I think of it, wow, it took 7 years to sort of illustrate proof of concept, but that's what we do. So one of the things, though, that emerged from this work, I actually consider this to be a real advance in the theory, and this was unexpected, but it occurred enough across multiple interviews for us to to create a formulation around it. So please just follow me on this. So the thing is that, right, let's say if you're able to hold on to the capabilities that are seen as marking you as a right full-fledged person within a local world, and you happen to have some stigmatizing status, could those capabilities then help you to defend against stigma of that status? And we actually found this to be actually the immigrants to report this to be quite a bit. So let me read to you some illustrative quotes. Most people in your community would think people with mental illness would make a person lose face. No, because he goes to work, still goes to work and he goes home. So yet that a person with mental illness continues to work, that is not considered a shameful thing. Yes, right. Another quote. What do you fear would happen if you tell your friends about your mental illness? The sky will collapse. He's sarcastic. There's nothing that will happen. I'm still young and I have my hands and feet, so I have my ability to work. I can work in any field, no problem. Besides, I'm married, no problem. So this person actually happens to have the twin capabilities of I can work and I'm married and perpetuate the lineage. So any stigma mental illness, basically, it can't touch me. That's what's his essential message. So this, I believe, really was a revelation to me because, if it's true, right? If what matters most can be utilized to defend against some of the worst aspects of stigma, what was so powerful, potentially powerful about this idea is that we can use this then as a roadmap to counter stigma in different local cultural contexts. Because again, to date, and to my knowledge, we haven't had good ways of articulating this or conceptualizing this. So I developed that work over a decade. And 2015, I was delighted by the opportunity to take this work then to HIV and HIV stigma in Botswana. Colleagues of mine from UPenn, as well as good colleagues of mine from Botswana. Now I've been working with them for 8 years on this. Botswana, of course, very different context. I also am new context for me, so I have I had zero knowledge about um, this country or even the whole region up until I was doing this study. So it was a wonderful opportunity. It is an wonderful opportunity to bring these ideas into a new context and condition. So a little bit about Botswana. There's free and accessible HIV treatment. Stigma of HIV contributes greatly to ART non-adherence, even though Botswana has achieved the 95-95-95 goals recently, which is astounding. But HIV prevalence still remains very high. Over 20% of adults have HIV. So today I'll be reporting on some ongoing work. So we completed formative qualitative work in 2016 to 2018. We finished a 2-year R21 pilot RCT, and I'll be talking about those study results in this next section. And then we've had the good fortune of having a small funded R01 around serious mental illness and HIV, and we're working on this multi-level stigma intervention, which I'll conclude. So just to start off, Botswana is a really tremendous context to look at this issue in. They have been very proactive in terms of their policies, in terms of enabling access to treatment for folks with HIV. And these timely policies have really improved population health that have enabled earlier detection and treatment of HIV. But due to the urgency of the HIV epidemic, which I'll talk about in the next slide, it was only after the implementation of these policies that stakeholder attitudes were actually assessed. So the question, it's possible that although these vital policies were unquestionably important in terms of, getting folks with HIV identified and into treatment as early as possible, they also could unintentionally reinforce a vulnerable position for certain groups. And I wanted to use the What Matters Most theory framework to illustrate this. So here's a timeline of some key dates in Botswana and the HIV treatment. Founded in 1966, there are diamond mines in Botswana. It's a relatively rich country in sub-Saharan Africa. They've utilized this funding to actually fund public health initiatives. So there's been free antenatal care since 1973. And then 1985, we have the HIV epidemic. 2001, there is an introduction of a nationwide prevention of mother-to-child treatment program. 2002, there's a launch of a national treatment program allowing free, again, access to treatment countrywide. 2004, there's an opt-out policy. So basically what this means is that everybody who comes into care, there's routine HIV testing associated with coming into care. And so people have to opt out in order to not receive the HIV test. So that was a lot. So let me just take a step back for a second. It's a couple takeaways. Free antenatal care. for decades. So women are used to having this right and privilege. But then also, there's also routine HIV testing attached to all medical care, unless you opt out. And women aren't necessarily, I guess, savvy or knowledgeable about the opt-out policy. So, and that could then in turn engender a certain dynamic. So within this context, I wanted to take a look at gender-based stigma. And there's been a lot written about this in Botswana and in different sub-Saharan African countries. It's not a new issue. The obvious culture and gendered aspects of HIV stigma in Botswana and sub-Saharan Africa have been seen to lead to blame and stigma towards women. There's a meta-synthesis on this in 42 qualitative studies. A lot of these studies indicate that women have their culturally based conceptions of promiscuity and immorality. Women are blamed for contracting HIV, spreading it to their partners, and then disclosure of HIV may then lead to abandonment by their partners. And so this is, again, written about in many different studies. So what we're hoping to do is, come at this from a somewhat different perspective. We wanted to see whether or not in the context of otherwise beneficial healthcare policies, when implemented in the context of gender inequality, could yield unintended structural consequences. So again, here, using this framework of what matters most or moral experience that we used in the Chinese group, and this time adding it to this concept of structural vulnerability, which I'll get into just a bit. So we published this work in AJPH in 2021, and we did extensive qualitative work. So in-depth interviews, 5 focus groups, and we interviewed per the Arthur's theory to really look at not just women with HIV, but men and women, all right, and both with and without HIV, because what matters most should matter most to everybody in the cultural context, right? Irrespective of whether you're a man or a woman, you may have a somewhat different take on it, but there will be areas of concordance. Same thing whether you have HIV or not. So we wanted to get sort of the universe of opinions. In this study, we used, again, similarly, the Perceived Stigma Scale by Bruce Link. We did a 2-step direct content analysis, and we had a multidisciplinary team. We met extensively, and I'll be talking about codes again around what matters most in structural vulnerability. So structural vulnerability is a concept that draws from Paul Farmer's concept of structural violence, except that it focuses even somewhat more on a person's position within the structural hierarchy and the potential internalization of having a disadvantaged position. So that's why this particular concept was useful for this study. So let's just jump into it again. What matters most from these folks' perspectives for women? And so a woman says, with known HIV status says, with women, if you don't have children, you're not really a woman. So so there it is. It's like, again, this is not for all women within Botswana, but for many women, this was the case in terms of either endorsing this or being certainly being aware of it. But I would say most of the respondents agreed with this. It's a very, very strongly held cultural value. A man says, proper woman is also judged in the community. Her standing is rejected by the way she takes care of her children, especially bathing them, making sure they have food, go to school. So it's not just having children, but caring for them in culturally appropriate ways. So you can also illustrate this. We also illustrated this by asking about not having children, right? And so here a woman reports, the community members will gossip. You're a barren woman. You don't bear children. You're like a bull in a crawl. Your purpose is to bear children, but you are a woman. You're denying your purpose. So again, here, it was, again, in this urban Botswana setting, this seemed to coalesce quite strongly around this very important lived value for women. So now let's bring into this the structural circumstance I talked about earlier in terms of the healthcare policies and the structural vulnerability that these healthcare policies could then elicit. So because antenatal care has existed for so long, and then there's this overriding cultural imperative for women to have children, they typically come into contact with the healthcare system first. Men don't come in unless there's some, acute physical problem. So women in young adulthood will typically come into contact with the healthcare system, and then they are subjected to routine HIV testing because, again, of the structural circumstances I talked about earlier. So both men and women recognize this, and men, unfortunately, take advantage of it. So here we have a quote from a woman. Men are reluctant to test, but women are required to do a routine HIV test during prenatal care. It's not like men are not sick. It's only that they don't go for testing since they rely on the women's status and assume it's the same as theirs. And so women get identified first and then unfairly blamed for bringing HIV to the partnership, even though obviously, it could have been the partner who gave the woman HIV in the first place. So the structural vulnerability we saw as being elicited by these two things intersecting. We had the structural conditions, again, of healthcare, free ART and antenatal care that, again, exists for decades. And then this leads to routine HIV testing and pregnancy. And then, again, because for women it's so important to have a child and to care for that child, be the foundation for the household, that then the confluence of these two things then led women to being identified first with stigma, and then that then set into motion all of these other things that I'm going to describe around what matters most in stigma. So again, if respected motherhood is a strong element of what matters most for many women in urban Botswana, the perceived promiscuity seemed to violate womanhood, and this again intensifies the stigma that's felt. So promiscuity basically directly undermines and attacks this notion of being a respected woman in this context. So a couple quotes here, first by women. Other people think that someone living with HIV was very sexually active and promiscuous, even though they may be wrong. They don't think of other ways of HIV transmission. Botswana mostly think that if you have HIV, then it means you had unprotected sex with multiple partners. So there's a promiscuity. And then a man says, oh, sorry. So prologue here. This quote is tough to read, but it serves a purpose. So I'm going to just put that hat on before I read it. So we take it that a woman belongs to the home. So we wonder if she has HIV, there is no woman in her. She's a lebolete, whore, there is no woman. So the reason I have this quote here, even though the language is extremely, very, very strong here, is because it harkens back to the concept of face. If you remember I showed you that slide around how when you lose an aspect of personhood, there's no way back. This kind of dynamic, I think, is reflected in language like this, where it's like, the person is gone, right? If you are seen as a promiscuous woman in this setting, it seems incredibly, incredibly difficult to come back from that. And so this is what I mean by, again, a loss of personhood, a loss of womanhood in this case. So again, we wanted to see was the reverse hold true, right? If we were able, in the context of this, let's say if we were able to promote these activities around or facilitate these activities around respected motherhood, could that then, right, protect women against the worst aspects of HIV stigma? And we did find some evidence to this case. So basically here, so I'll just read you some of these quotes. So a man says, the woman who has HIV will be treated better having children compared to a childless person without HIV because that person has dignity. And then another man says, as long as a woman keeps caring for all the children like before and nobody actually witnessed her sleeping around, and it happens that she's HIV and she stays that way as a caretaker, people won't change how they view her as a woman. So again, it's this concept of if you can somehow maintain or preserve these things that are, seen central to womanhood, it seemed to be able to fend off the worst aspects of HIV stigma in this setting. So I love qualitative work. I love theory. You can see it, reflected in the previous work. I'm actually also a quantitative social scientist, believe it or not. And so, and this is where I'm going to bring this now into quantitative measurement. So what we did is in order to see whether or not we could, excuse me. So this qualitative work illustrated the concepts. Now I sought to bring into measurement. And I did this actually by creating scales that would reflect both how culture shapes stigma and then how culture could protect against stigma. So I'll give you an example here. If you remember from the Botswana quotes that I read around being sexually active and promiscuous, etc., this quote I read to you a little bit earlier on. What I did then, our team did then, is we created a measure that tried to capture this quantitatively. So this particular item reads, most Botswana believe that a woman with HIV was promiscuous before marriage. Okay, so it captures the dynamic reflected in this quote around what matters most and how it could shape stigma. So what we did is we created, and ultimately there were 10 items per subscale. We had a cultural factor shape stigma, and an exemplar item here is exactly the one I just showed you a second ago. So most Botswana believe that a woman with HIV was promiscuous before marriage. Again, culturally salient, right? Stigma finding in this context. And then for the second subscale, we had cultural capabilities protect against stigma. So 10 items, I'll read you an exemplar item. So most Botswana respect a woman with HIV who raises successful children. So again, right, achieving these capabilities could then fend off stigma. We tested this among 98 individuals identified with HIV. And I want to thank Dr. Kalishman, if he's here, for for ultimately accepting this manuscript, and anybody else, because we're very happy to publish this in AIDS and Behavior. So we subjected this to a constructability test, and I'm going to focus on the second subscale. It's on how the culture could protect, because again, I think that's perhaps even the more innovative kind of derivation, sort of application of Arthur's theory, and that because again, it could provide a roadmap to social integration for people with HIV. And so what we did is we did a constructability test against a widely utilized stigma scale, HIV stigma scale. We could have chosen among several very well-known ones. We chose the Berger in this case. So the Berger stigma scale is associated with depression, positively with depression, negatively with social support, negatively with self-esteem. Question is, how did this culture protect subscale associate with these different concepts? And the pattern should be different, essentially, and opposite, if ideally. So what ends up happening, actually, thankfully, so the proof is in the pudding, I like to say. So the Berger stigma scale, it acts how you think it would. More HIV stigma, more depression, more HIV stigma, less social support. But the culture protect scale actually acts in an opposite way. It actually is, the more this construct was endorsed, the more social support endorsed, and the same with self-esteem. These are modest but significant associations. And I'll say this again in more plain language. So if a woman believed that fulfilling these capabilities around respected motherhood could fend off HIV stigma, this was also associated with more social support and greater self-esteem. And again, acts in a different and opposite way from the Berger stigma scale. So, I was pleased to see that the ideas also, demonstrated relevance quantitatively. So since then, we also took it and applied it in this R21 proposal, where we did a 2-year pragmatic trial. There's the decreased stigma among an intervention group versus a treatment as usual group. So again, I want to certainly acknowledge this is a pilot trial. We didn't even, test it against a treatment attention control. It's just a treatment as usual. And for this intervention, which is actually provided to women during pregnancy, the intervention itself is co-led by a counselor and peer, and there are 8 weekly sessions at about 16 minutes each. We used evidence-based practices to reduce stigma, so psychoeducation around HIV, cognitive restructuring through cognitive behavioral therapy around countering stereotypes, and then coping skills to promote actual adaptive behavioral, coping within the context. But what we used the What Matters Most framework again to bind all these around the intersectional aspects of identity of being a woman pregnant and living with HIV, and again, in particular around these capabilities of respect. And so you can see here, actually, we conclude the intervention, and this was chosen by the women. We can, ask them what would make sense and what would be most powerful for them. The shawl ceremony. And so women in Botswana, when they achieve marriage status and they're ready to be a mother, they actually receive like a really beautiful shawl. And so at the end of the intervention, we provided this to the women, and you could see this here. And just anecdotally, I just want to report, when I was sitting in the first intervention sessions, the despair in these women's, just in their experience was incredible. I mean, women talked about suicide, about really abuse and poor treatment from their partners, etc. And then from there to the end of the intervention, and you could see here, the women's faces really a lot of radiating with joy. I think we achieved something positive. So in this case, what we did is we assessed women at baseline. So this was during pregnancy and the 4 months postpartum. So we wanted to see whether or not the stigma intervention had effects, right, following at longitudinal follow-up. And then infants were assessed at birth. And so then these are the main findings from this pilot trial. And again, N is very, very small. Unfortunately, we did this trial during COVID. So, I wish that we had more, a larger sample, but I'm happy that we were actually able to pull it off. So this is published in 2022, Age Research and Therapy. And what you can see here is that basically, and we unbalanced the arms because in order to maximize power, because we knew that we were not going to get to our target. So we had many more folks come through the intervention. And in a nutshell, this is a difference in difference analysis. So between, again, baseline and 4 months, what we can see is that depressive symptoms decrease, HIV stigma decreases. So that's all well and good. And what gives a little more confidence that this isn't just a naturalistic decrease is that during the control group, there were actually women, again, and very small, but the women increased in the control group over time in terms of depressive symptoms and HIV. So we think it's probably not due to these effects, are probably not due to just naturalistic decreases. Hopefully we were actually doing something to help the women. And then, again, very preliminary findings, but we had, favorable Cohen's d with, of course, all the caveats I've mentioned before. With the gestational age, we also had an intriguing finding. Again, I don't want to make too much of it, but it was there, so I'm reporting it. In the intervention group, the women gave birth at 39.6 months. Control group, 38.2 months. It does meet statistical significance. Again, don't want to make too much of it though, because the 38.2 months is weeks. 38.2 weeks, 39.6 weeks is also full term. So, but intriguing finding, and we'd like to follow up on it. So, all this to say, it was very gratifying to see this, and that it looks like things are, going in the right direction. And obviously, we want to, test it in a more rigorous way moving forward. So, so coming back to the beginning of the Botswana, part of this presentation. So I showed you how we utilize what matters most in an individual level intervention. Again, bind together psychoeducation, cognitive restructuring, and coping skills. These are the evidence-based practices, and we geared them all towards resisting stereotypes of promiscuity, promoting safe disclosure to achieve respected motherhood. And we have some, nice pilot findings, but, to be replicated. But what our study also showed us is that we really need to act as well on the facility level. And so this is where a recent collaboration with incredible, fantastic colleague, Lauren Eyeblade, comes in. I'm sure you all know her work and total facility approach. So in the past year, we were able to work with her, and it's such an honor. And we took her intervention and worked with her very closely in her intervention, and also which focuses on attitudes of HIV acquisition, addressing awareness of stigma, addressing HIV attitudes, addressing the facility environment amongst HIV clinic staff. And again, gearing it towards that staff are aware and better help pregnant women with HIV cope with the consequences of HIV stigma, and to develop programs to help pregnant women cope with HIV stigma. And we very much tailored it again, to these notions of promiscuity, etc., that women face, and how it erodes their standing in the local community. And so we were able to do just a feasibility test of this. We did it in 2 clinics, and basically we are setting up for a larger trial. So we don't obviously. So we've done a pilot test on the individual level, feasibility tested it on the facility level. The hope now is to actually combine them and see if we do combine it, does it have a synergistic effect? Do women that come through clinics that have gone through this program, as well as individually have received this program, do those women do even better, for instance, than women who would experience one or the other? So hopefully, if we can get NIH to see the wisdom of this approach, we'll be able to report on this in the future. One slide just in terms of application of cancer stigma to cancer stigma. This work is just beginning. So again, if what matters most in Botswana, I've talked about extensively, is respect to motherhood for many women, again, in traditionally thinking in urban settings. This could apply to something, for instance, around breast cancer and the stigma associated with breast cancer. So you can imagine how, if motherhood is prized, that this could exacerbate cancer stigma. In anecdotal just conversations I've had with cancer clinicians in Botswana, they were astounded that how highly stigmatized mastectomy was and how resisted it was by women who even were at enormously high risk for developing cancer. And so, and it didn't make sense to the clinicians. They were saying, well, you can take this step and really, probably, save your life, essentially. But what I think, how this theory, I think, enlivens this whole understanding is that you're actually asking the woman to choose between 2 deaths. It's a physical death or a social death. And the two are actually not that far from one another in terms of importance. And I think that's, if I can sort of leave you with that point, then I feel like I will have achieved today's sort of aims. And then a way to protect against cancer stigma is that they can still meet that. Again, this would be a message that you could test, that women could still meet key maternal roles even if you had a preventive mastectomy procedure, right? Could that then mitigate stigma and hopefully facilitate willingness to take up this preventive procedure? Okay, so my conclusion slide. So I hope I've taken you through this journey of these ideas. I'm eager to get feedback from all of you. What matters most, that stigmatized individuals are seen as violating what signifies personhood, or sort of full-fledged membership within a cultural world. This concept can be used to reveal both cultural and structural ways to mitigate stigma. We've utilized this concept more recently to really illustrate the structural vulnerabilities that people may face, in this case, women with pregnant women with HIV. Structural conditions could reinforce structural vulnerability that then perpetuates stigma, And then the future directions include measurement, as I've talked about, intersectionality, which is an area that I'm really excited to bring this set of ideas in, and how can it further illuminate having multiple, stigmatized statuses and having structures that compound the disadvantage. And then lastly, as I talked about, the multi-level stigma intervention between combining individual and facility level stigma interventions. So I want to thank you all so much for, again, your attention and for this great opportunity just to present these ideas to all of you. So thanks.
Thank you so much, Dr. Yang, for an absolutely fascinating presentation on so many different kinds of work. Again, deeply interdisciplinary and really drawing on one set of questions to move, from a more theoretical space into a deeply applied space with implications for clinical care, for training of healthcare professionals, for the workings of healthcare facilities. And I imagine there are questions folks would like to ask. We have about 6 minutes, so not too much time. But if anyone would like to go ahead either and unmute themselves or raise a hand or drop a question in the chat, all are encouraged to do so. And as we wait for others to bring in their own questions, I would just say, as someone who's trained in medical anthropology and who read Kleinman's work on, questions of what matters most and moral experience, sort of when they were fresh and hot off the press, and who's been thinking with those concepts for many years. And I'm really thinking about both the ways in which the work that you're doing in these different clinical spaces has reverberated through my own training and my own scholarship. And also the really, I think this is really the power of InCHIP, to host conversations across fields and disciplines, because for me, this is probably the first time I've had an opportunity to think in a clear and organized and well conceptualized way about how the kinds of insights that we as medical anthropologists develop about the lived experiences of stigma, the deeply particular, localized, culturally, politically, economically informed experiences of stigma, can be kind of turned on their head by those who have an explicit interest in developing interventions that can prevent or mitigate stigma. So, we were chatting just a little bit before things got started about whether your interventions would resonate with a medical anthropological sensibility. And I would say for this medical anthropologist, the answer is both yes, absolutely, and also how very exciting to see these kinds of transfigurations of insights into ways that can have profound implications in the lives of people who are, as you suggest, living with tremendous structural vulnerability and disadvantage.
May I reflect something while we're waiting for questions? I would love for you to maybe just get your quick snippet of a. So thank you, number one. Number two is that, the work that I do and you do, I'm sure, seeks to really privilege culture. You know what I mean? Like really honor it for what it is and to really bring it to the fore, right? What I run into a lot with now that I'm thinking about intervention is sort of this tension between seeing culture for what it is versus changing culture towards what it could be, right? And then and it's very interesting how those two things collide because another person, so while I believe these ideas have merit, another person could say, well, the social roles that women find themselves in Botswana are very, very restrictive. And so do you really want to sort of promote those things? Do you know what I mean? Because then in turn you may be promoting other things, and that could be harmful. And I think that's a great area of inquiry. So I just wanted to, and I've been thinking a lot about it. I'm just wondering if, yeah, you or any others had any thoughts about that.
Sure. I do want to leave space for others who might.
I'm sorry.
No, but no one's lifting a hand, so I'm happy to offer my own 2 cents. And I think, my answer would be, and this is going to be sort of true to my own training and discipline in medical anthropology. Often we're thinking about, there are a couple things that we tend to have in mind. One is the question of, the sort of classic anthropological question of when is it appropriate to try and intervene and change how people in a particular setting think about or interact around a particular topic or theme, and the questions of the presumptuousness of the ethnographer. And of course, anthropology has a profound, history of embeddedness in colonial projects, and there are skeletons in the anthropological closet for sure. So that's one set of questions that comes to mind. Another, for medical anthropologists in particular, and those of us in our InCHIP community who hang out with anthropologists know this, we often are looking, right, if culture was sort of the classic central concept for anthropology in past decades, now we're really interested in structure and how culture intersects with structural factors, economic, social, political, ideological factors. And so then the question becomes, okay, what's our leverage point? Is it in the political sphere? Is it in the political domain? Should that be where we're trying to intervene for change in the interest of health justice, health equity, et cetera, right? So that's, one response to what you're asking would be, well, what we really should be doing is trying to change the structural circumstances in which people are facing disadvantage, exclusion, marginalization, stigma in the first place. But I think what you're taking us to is a different kind of place and a different kind of answer. And I think ultimately, I would suggest that the answer is not an either or, but a both and, right? That there are kinds of analytic work and kinds of translational work that ought to happen at the level of transforming structures, systems and structures. And then there are other kinds of analytical work and transformational work that ought to happen at the level of clinical interventions for the benefit of individuals who are suffering and who are struggling within conditions that haven't yet changed. And so I would say that's where I see the real power and innovation of the kind of work you're doing, and I would say we also need to, anthropology needs to look into the dark secrets of its history, or the dark sides of its history. Collectively, those of us working in the health domain need to think about systems and structures and leverage points for change. And among those leverage points at the level of individual experience and clinical care is the kind of work you're doing. And here I've gone ahead and given a very long-winded response rather than hearing from others, and we're at time. But perhaps you'd like to close with a final thought,
Yes, thank you. It's my fault. I went over, I'm sorry, I gotta, you get excited about ideas. But I would invite people, please, if you have any inquiry or just want to have a follow-up conversation, I'd be delighted to engage with you. So as a makeup for going over too long. So
Well, thank you so much for sharing such extraordinary work with us today, and for visiting us. And thank you to all those who joined and took part in today's event. And have a wonderful afternoon.
Thank you so much, everybody. Bye for now.
Thank you.